And thanks to Mandy for allowing me to do this talk. I'm really privileged to be able to share with you guys. So I think if we look at the COVID-19 pandemic, it's really been a challenge to us as to how to respond to this. I just want to see, Chris, it seems like I can't advance my slides.
You might have to just try and maybe unshare and then share again and see if that helps.
Is that better?
I'm not seeing anything. I'm not seeing your slides just yet. Have you started sharing again?
Yeah, let me just try to go back. Can you see that?
Yeah, I can see it now.
Perfect. Sorry about that.
No, not at all.
So I think as we looked at the COVID-19 as it hit our shores, the first thing was really the fear that we all sat with. Will I be safe? How do you protect your family as a healthcare worker? What about PPE? Did we have enough? The question was, you know, does Netcare know what they're doing? I think this was something that I heard often. And again, it was really a very uncertain times for all of us. And do we think that our management people care about us? And I think as time went along, I must say from my point of view, I must salute the Netcare management and the hospital staff in each of the hospitals for doing an exceptional job really to keep all of us safe. So just as an introduction. So when we look at COVID-19, and I'm sure you've seen this type of slide many times, it really goes about how does this virus differ from what we had seen before. And it's really not just a bad flu, as some people would call it. It really had a lot of sequelae, and I think we're only now starting to see how this affects people after they discharge from hospital. So we've been very successful in allowing people to get back to their families. So the management that we've been able to do, and because we've been delayed from the international experience, we really had the opportunity to learn from everything that they had experienced, and we could apply the best practice to our patients by the time we had the peak of this pandemic. So if you look at the biggest learning point, it was about the thrombotic risk. The reason why I'm sharing this is that it influences very much how we continue treatment of our patients in the long run as well. So it's not just about that immediate management of the patient, it influences what we discharge our patients on. So keep this thrombotic risk in mind, because that will really affect every organ system in the body, both arterial as well as venous, and it has an implication again as the outcome of the patients after discharge from hospital. So if we look at these are pathology slides that were investigated of people who had passed away. And you can see that the airway is absolutely blocked with this thrombotic sludge that is an inflammatory response in the airway itself. And we've seen quite a bit of situations where the patients have an ongoing productive cough. We've seen the other side where people just have a dry cough. And there's a very different phenotype that is differentiated between these two presentations. If we look at how this virus then affects the lung, it causes a microangiopathy. So it causes this inflammation in the little blood vessels as well as in the lung itself. And this actually causes what's called angiogenesis, where the blood vessels thicken and we have the vascular complications that could happen. And this seems to be the reason for what's called pulmonary fibrosis that they've coined as an after effect of COVID-19. Many patients recover without any sequelae, but unfortunately some do have this pulmonary fibrosis, and people could even become respiratory cripples if they have a severe form of the disease. It seems to be predicted by those patients who have a very high inflammatory response when they first present. And this really gives us an indication of what to expect in those patients in the long run. So we've had these trials that are presented to us. So first of all, you had the abstract, which looks beautiful, fantastic. Then there was the introduction, which looked a little bit less acceptable. And then the results was really not what we expected at the start of the trial. And this really influenced significantly how we had to sort of learn from the international experience to be able to understand how our patients should be treated. And I'm sure you've all seen the clip from the Dallas or Texas somewhere, where this lady told us how important it is to use hydroxychloroquine, and this was saving patients' lives. Well, I think her claim was disputed. Apparently there was some psychiatric history in her. And from that point of view, again, we had to sort of sift through the data that was coming through to us to ensure that what we were treating our patients with were giving them the best possible option of recovery. If we look at some of the aspects that really influence how we manage our patients, one of the important ones is this viral excretion and how this evolution of the viral excretion affects how quickly people can actually return to work. Now, as you know, we all initially worked on 14 days, then it was lessened to 8 days, and now more recently 5 days, because the period of time when you can actually spread the virus from yourself if you are infected is much shorter than what was previously anticipated. So you do have some people where the viral particles may persist, and if you did retest them, the COVID test would still be positive, but they would not be able to infect anybody. And I think that's really important to understand. So to retest people is completely a waste of money and time. You can see that some people may have persistence of some viral particles for a number of days, which does not mean that they can then spread that infection to somebody else. If you look at how some people were sort of called the super spreader, so they, in their immediate environment with the number of people that they had contact with, could really then influence the viral spread to other people very rapidly. And this is why the masks and the social distancing and the hand hygiene is so crucial, because even now that we have reduced numbers of people with active infection, and even PUI patients, very few now are actually found to be COVID positive, this does not mean that this risk is completely gone. And I think we've learned from countries such as New Zealand, who thought that they had no virus in their country, and then suddenly some cases popped up, and they actually did have very significant numbers, which quickly then translated into the virus spreading in that community. So we have to just have this ongoing awareness that even though we're not at the peak of the pandemic and the numbers are going down, that the risk of infection still remains, and we have to continue to be vigilant, even if we do admit patients with a PUI, to understand that that patient could still be COVID positive. And in our community and wherever we move amongst people, even amongst colleagues, that we keep this in mind, that every person around you is COVID positive. You've got to just have that mindset. And because of that, you have your mask, you wear your visor, because really the visor has added to our safety significantly. The mask is one thing, but the visor makes a big difference in our work situation. So I think it's absolutely crucial that if you see a person with a mask, but their visor is not on, that they should be aware that the visor is absolutely important. It's not good enough just to have the mask on. In our community, where we work as healthcare workers in a hospital setting, where we have a concentration of people that might be COVID positive, and those may be colleagues or then patients as they come under our care. If we look at the immune response, countries such as the UK and Sweden were under the impression that there would be what's called herd immunity, that the community itself would then create their own immune neutralizing antibodies, and this has been found not to be the case. That's why the UK and Sweden really had lots of cases. That was unexpected in countries where their health system is supposed to be first class. So if you look at the neutralizing antibodies, unfortunately, it's been shown that these do not last. I don't know if you can see the graph on the right-hand side, but it shows that although they're good antibody response initially, it may not persist. So some people may have antibodies for a few weeks, others maybe for 6 months, but the antibody response may not be adequate to give you immunity against the infection. And so there's been reports from overseas that repeated infections do happen. So when a patient is discharged home, it's not to say that they're not going to be at risk again, especially if they return to work or whatever the environment is where they find themselves. It's important to warn them about that. And this is why, until this is completely eradicated from our community and our society, that we have to have this awareness that the virus could still be around and people can still be infected. It's also important from that point of view that a person has to have that mindset that they have to wear their mask, they have to continue with social distancing, and they have to just really, the hand hygiene is absolutely crucial to keep on having that awareness. Not that they think if they've had the infection, they're now going to be immune to getting it again, which is not the case. So if we look at the practical side of how these patients presented, I wanted to just mention these two phenotypes. The one is the patient with the high pulmonary elastase, where the lung is actually very resistant. These patients needed a high PEEP and you had to ventilate them with a lot of ventilatory support. And then the patients who had a more pliable lung, they usually had the very dry cough, crepes at the lung basis, and they had a very different course. And oftentimes we could get these patients out of hospital much quicker than the first case that I showed you. So if we look at what has really made one of the most important reasons for survival on these patients, it's been the fact that they could be anticoagulated. We found that they have a resistance to heparin and that you had to use higher doses than normal of heparin to get an adequate response. Now, this is important because when we discharge the patient, they should continue to use an anticoagulant such as heparin. Clexane has been the most common one that we've used. And more in the recent few weeks, Xarelto has been used, one of the DOACs, because it's also been found to have antiviral effect. So we would use the therapeutic level of 15 milligrams of Xarelto twice a day, depending on the patient's age and renal function, and then to continue for 10 to 14 days after discharge from hospital, or until you're happy that the acute inflammatory response of the disease has cleared completely. We know that with good anticoagulation, these patients' survival was significantly better. If we look then at what do we discharge these patients on, the commonest has been that we would go with Clexane initially until we then heard about Xarelto. So Clexane was given as a therapeutic management, usually 1 milligram per kilogram, and even slightly higher depending on the patient's response. And we looked at the factor 10A levels of around 1 or slightly higher than 1 to get to this desired level of anticoagulation for the thrombosis that I showed you in the first few slides. Xarelto, again, as I said, 10 to 14 days after discharge. And if there's any thrombotic risk, for example, we've had some patients who presented with massive pulmonary emboli, they should have the full treatment for 6 months, and they would have an ongoing evaluation to see if there's any additional risk of pulmonary embolism after that period. We've given vitamin C. There's been some recent studies that sort of disputed whether vitamin C was actually useful, but I do discharge my patients to complete at least 10 to 14 days of treatment. Vitamin D is just given initially and then once a week, and that did seem to make some difference to the patients, but again, not a massive influence. We used thiamine mainly to stop any kind of oxalate crystals from vitamin C. And then nicotinamide was an additional agent, 25 milligrams a day or 100 milligrams, depending on the situation. Colchicine is interesting because this is usually used for acute gout, but we know that it has an anti-inflammatory effect. And we've seen some patients presenting with raised TROP-Ts or TROP-I levels, and the colchicine definitely has a beneficial effect again on the inflammatory response in the lung as well. So not just in the patient that had any evidence of a cardiac dysfunction, but also for this inflammatory response in the lung, which we mainly checked with interleukin-6 levels, ferritin as well as LDH. CRP has been helpful, and very few patients actually had a raised temperature. So this monitoring of the temperature has actually, I thought, been a waste of money and time. Antibiotics, many of the patients did have a secondary infection, bacterial infection especially. So we did use azithromycin, Zithromax, which again had an immune modulatory effect on the lung. But then we would cover with an antibiotic, especially if the CRP was elevated. And we saw really markedly elevated CRP levels in some patients. And they did very well with an antibiotic. It could be something simple like Augmentin, or more aggressive therapy if there seemed to be a purulent sputum. Oxygen requirements has been quite variable. And for some people, we did find that giving them home oxygen, maybe for a week or two or a month even, was necessary, just to ensure that they didn't have a relapse and that they did not remain oxygen dependent. And of course, oxygen in that situation would also help the lungs to heal. Physiotherapy has been absolutely crucial, and our physiotherapists have worked tirelessly to get these patients better. And a lot of it had to do with showing the patient how to clear phlegm, how to actually use the incentive spirometer, how to monitor their oxygen saturation, and what to do to strengthen their cough reflex to clear the phlegm from their chest. You found sometimes that the phlegm was quite sticky and the mucus was very productive, sometimes even with hemoptysis in these patients. So physiotherapy as an outpatient, absolutely important, especially in the person with any kind of pre-existing lung disease. And again, the physiotherapist would be able to give us some guidance as to people who were not improving as expected. Chronic medication is important because we have to ensure that the patient is not taking any medication that could interfere with their recovery. And this would especially be agents such as anti-inflammatories that may affect their kidney function, especially in the older patients. Importantly, from that side is to ensure that if they are on anticoagulation, that they understand the risk of possible bleeding, and that if there should be any features of that, that they would immediately respond and inform their doctor of this event. So when you discharge the patient, what do we tell them? First of all, you have to inquire who is at home. Can you infect them? Is it possible that you, when you go home, could still be a person of concern from that point of view? Again, most of the times the patients had stayed in hospital for 5 to 6 to 7 days. If they were in ICU, it might have been a bit longer, to 10 to 12 days, depending if they were ventilated or not. So at that time, again, we can reassure the patient that we're discharging that they really would not be able to infect those people at home, but also to consider that those people at home may have had the virus and didn't know about it. So again, the same thing about being careful, even at home with the people that you know, to ensure that you don't have any kind of risk to one another by spreading the virus. What about how do you protect yourself in the future? And as I said before, we don't have immunity even if you've had the virus infection, and you have to consider that you can get it again, and you have to continue to be careful. Can I get it again? Yes, unfortunately, as I've said, the immune system does not give us that security that the antibodies that we do present can give us an immunity in the long run. What about work? And most of the time we've asked people to try and get back to their normal work situation as possible. Some people have been quite scared. Importantly, from that point of view, is people feel fatigued. And it is definitely so that once you've had the virus, it took some time for that fatigue to get out of your body. So I've recommended to them that they give themselves time, and we've often even up to 2 weeks suggested that they just take it very slowly before returning to a full work day, and to be able to understand that there is that period where they may feel fatigued before they can get back to normal activities. And during that time, we've recommended them not to exercise because it is important for the body to rest, to ensure that there's no risk of any inflammatory response on the heart, and that they're not at risk of an arrhythmia. What about the concerns for the future? Most importantly, that we've all been concerned about the mortality, and now more importantly, the morbidity that we've seen with COVID-19. This has really been of concern, looking at people who've been discharged home who could develop this lung fibrosis that we've seen in some patients. It seems to be limited to those who've had a very severe form of the disease, and people who had been ventilated may be at risk of developing this. Here, we would then recommend that the patient sees us in follow-up. I've been doing lung function tests on my patients after 10 to 14 days to ensure that there's no risk of lung fibrosis. If there's any evidence that there could be an inflammatory response that is ongoing, what we do is we do look for the inflammatory markers such as interleukin-6, the CRP, and we can look at the ferritin response, which is an acute phase reactant, to see if there's any risk in these patients of ongoing disease and possibly the need for intervention. One of the things that's really struck me, because I have a big diabetes practice, is how many patients presented with poorly controlled diabetes. Many of these patients had never seen a specialist. They may have been at their general practitioners. Their treatment has really been inadequate, and their HbA1c levels have been markedly elevated. We've also seen a number of patients that presented as newly diagnosed diabetics. And the stress that the COVID-19 has presented on their bodies have then shown up the diabetes, which could have been in the pre-diabetic phase of insulin resistance. This is important not to miss. And if there's anybody where there's any new symptoms suggestive of diabetes and they've been COVID positive, it's really, really important for them to follow up to check that they're not maybe diabetic and that this was missed. If they are diabetic and poorly controlled, diabetic control is absolutely crucial, because what's important from that side, that the high glucose levels can actually accelerate the inflammatory response. We've also seen that very overweight people with diabetes were particularly at risk of this inflammation that seemed to drive this whole pathological process seen with the COVID-19 virus. There's a high prevalence of diabetes in South Africa. The NHANES data from 2012 showed us this. Something like 30% of our Indian population have diabetes, 12% of our colored population, and 8% of our black population and 8% of the white population have diabetes. So a significant number of people that we know of living with diabetes already. It's really important not to miss these patients in the context of the COVID-19 pandemic. Comorbidities have really been a challenge, and it's also shown us with this pandemic how many of our older patients have no social support. Advanced age has been an absolutely deadly part of how this disease has affected us. And unfortunately, from that point of view, we did lose a number of older patients, usually above 80 years of age, with comorbidities, and also those who came to hospital late and could not be saved because they presented late with advanced disease and we couldn't improve their outcome. From that point of view, unfortunately, there's still a fear of coming to hospital. And because of that, patients have delayed their normal therapy, even sometimes neglecting cancer symptoms and other comorbidities that needed chronic treatment because they were too scared to come to the hospital. In a way, the hospital is the safest place because that's where we are more aware of COVID and we really take protection very, very seriously, both for ourselves, our staff, and for our patients. So really the message needs to go out to the community that in fact the hospital is the safe place. It's not a place where you can get COVID. That's where you're actually best protected, and not to delay to seek medical attention for any kind of illness that they might have. There's been a huge aspect of fear and psychological challenge that this COVID-19 pandemic has presented us with, especially because of the mortality rate. And as healthcare workers, we've had a fatigue really having to deal with these patients, having to deal with PPE, having to work under very difficult circumstances. Sometimes just wearing PPE, being so uncomfortable, has been a challenge in itself. And so it's been important that we understand this fear and the psychological impact that even the lockdown has had on people, and that this has really been an aspect of this COVID-19 that was completely unpredictable as far as the long-term sequelae is concerned. And it's given all of us that uncertainty, really. If something like this could happen, how certain is the future? And that fear must not be underestimated. It's really important that it also falls into this post-traumatic stress aspect of looking at this COVID-19, and that psychological support is really important also for our healthcare workers, but also for our patients and their families as well. The late complications, as I've mentioned, the others that have come across in case studies have been bronchiectasis, where there's been chronic damage to the lungs, and then neurological complications. There's even been psychosis, and other complications like encephalitis can happen. But again, these are rare cases and only have happened in a small number of people. In the long run, in the conclusion then, we've luckily had a very rapid response to this pandemic. There's been a lot of negative discussion about how the government managed it. I think the government did the best that they could with the information that they had. It's a very difficult thing to predict. When is it good to do lockdown? When should you lift lockdown? What should you prevent? There's been a lot of criticism of how it was handled. But I can tell you that if you look at the outcome in South Africa and the number of cases that we've managed to get home to their families, the way that the pandemic has been limited, I think the government has done the best that they could with the information that they had available at the time. It was a rapid emergence of the virus. It quickly spread to the rest of the world. And if you look at that, again, very difficult to contain in any reasonable way, and keeping it from our communities. And really, unfortunately, it is a difficult thing to predict, to try and anticipate what would happen. And even the numbers that we saw was difficult to try and predict. But I think that if you look at where we are at the moment and that we've been able to release the lockdown, this has really been an impactful intervention by our government to be able to get to this point. We've accumulated a lot of knowledge on the virus. We've also learned from the international experience, but there's still a lot of unknowns. For example, why not children as much as we see in adults? An interesting here is that the immune response in the lung and the ACE2 receptor that the virus binds to has a very different response in children, and that's why they were particularly protected. So in schools, for example, it's not the children that's at risk, it's the teachers, because the teachers really come with the virus to the school possibly, whereas the children are mostly protected. The immune response, as we've said, I've discussed that already. Are there people who could act as reservoirs? We don't know that. But again, there has been some identification of what's called super spreaders, and they've been identified as people where they immediately impacted a large number of people in their immediate environment. How long will the SARS-CoV-2 virus remain in circulation? Is there a chance that there could be herd immunity developing? All of these are unknowns at the moment, but again, it is something that we just have to continue ensuring that people are vigilant and that they protect themselves as best as they can. What about other viruses, for example, influenza? And even at this late stage, it is still worthwhile to have the flu vaccine for the normal influenza annual one, even if you haven't had it before, because there seems to be some protective effect if you've had the flu vaccine to not get as bad an infection with COVID-19 should you contract it, or that it actually doesn't affect you at all. Although it doesn't convey any kind of immunity, it does seem to give us some protection. Antivirals and vaccine absolutely urgently needed. As you know, there are now 2 vaccine trials in South Africa that the MRC is busy with. and hopefully these will culminate into a vaccine that will be effective. In some countries, a vaccine has been promulgated as being very effective. This is specifically from Russia, but they have not followed the guidelines to ensure that the vaccine is safe and that there's no long-term side effects to the vaccine. So I think the way that the South African MRC is approaching the vaccine development is scientific and very sound, and we should wait for their results before we would embark on using this on a wide scale. So if we look at what I've said, I hope that this has given you some insight. I'd be happy to take questions. Are we going to beat this virus? I think yes, we can. Thank you very much for listening.
Thanks so much, Adri. That was really, really good. Thank you. There are some questions on the sidebar if you want to go through them.
Okay, let me just see. Okay, so how long after the initial infection has cleared up will a positive test indicate reinfection? So this would really more look at your clinical features rather than just to look at the PCR test. So the PCR test, because it's so sensitive, can pick up small viral particles, which doesn't mean that you're infected again. So you would rather look at the lung features of infection. Are there any, is there a fever, for example? Could that have been present? Is there a new cough? And any new lung signs, chest x-ray findings, etc. So it's not a blood test that will show you whether there's a reinfection. It would really be the clinical presentation. The international experience has been that this could happen 3-4 months later. And as I said, they've only seen it really in people who had a very severe infection to start with. So I hope that's answered that one. Okay, do you reckon that, yeah, look, the temperature screening, I think is absolutely a waste of time. Most of these thermometers that they've used have recorded very low temperatures. We've sometimes seen, even in severe cases in the intensive care unit, that the patient had no fever. They could have a CRP of 300, but no fever. So I must say that we didn't find that fever was a very good indicator of the severity of the illness. Again, it is a requirement from the Department of Health, but I think a lot of money has been spent on doing this and recording temperatures when it's really not helped us much at all. I think what is the real story about antibody testing? There was a suggestion that the antibody test that is available was going to be reliable, and SAPRA has then withdrawn their approval of the antibody test. So at this moment in time, really, I don't think the antibody test has got any kind of influence on how we should interpret whether there's any kind of immune response or not. It may just show you had the infection. And again, it doesn't really have any bearing on whether you have immunity or not. So the antibody test for me is at the moment really a moot point, and I don't think that it has any relevance on clinical interpretation of the infection or the sequelae thereof. So if you can get it more than once, how can the vaccine help us? Now, the idea with the vaccine is that it would give you a super response. This is the same idea that they tried with the patients with recovering infection, where they tried to use the serum because it had a high antibody response. And then if they gave that to a person who was ill, the idea was that the high antibody response could then fight the infection better. The vaccine would have a different mechanism like these vaccines would do, because so far the SARS COVID-19 has not mutated, although they're different serotypes. So it's still quite a contained type of virus. So a vaccine should be possible, different to the HIV vaccine, which has a lot of mutations and much more difficult to get a vaccine against it. So I think that it's important that from that side, the vaccine is really a possibility, and it will give us that antibody response that would be effective enough against the virus itself. Let me just see the other question here. Do you require temperature? If the immunity we get does not give security that we cannot be reinfected, what can we expect from the, okay, we've answered that one. when is SARS-CoV-3 expected? Okay, so if you had, if you were clairvoyant and you had a crystal ball, it's very difficult to know. I think it's important that, again, I don't think it's the end of the SARS viruses. If you see how initially the SARS virus with the bird flu, and then with the MERS, and then now with the COVID-19, again, these viruses may be in our immediate future for a long time to come. Unfortunately, I don't think it's the end of what these infections are going to do to us. And maybe it will just give us a much more awareness that these viruses are around, and to take greater precautions when we travel in our community, and also if we have any kind of social interaction. How is the follow-up done when you are diabetic and you've just been diagnosed with no serious symptoms? So I try to get my patients back within 2 weeks. They all get a glucometer. They see a diabetic educator as well as a dietitian, and we then see them in follow-up. And from there, we follow up what their home monitoring does to ensure that they react quickly and that their sugar gets under control. They're very easy to control once you get them on the correct management. And I think with the new treatments for diabetes available today, really, that this is something that's very easily managed. It is important in the public sector, for example, at Charlotte Macheki Hospital, that they reported even at times having 3 diabetic ketoacidosis patients presenting in a day. So that we, in that situation, in the acute event, not misunderstand that the hyperventilation that we're seeing could just be from the COVID infection, but that there could be diabetes underlying, and not to miss the patient presenting with the ketoacidosis with COVID. So that is important. So those patients obviously would be on high insulin infusions, and then once they stabilize, one could decide whether they need insulin as long-term treatment or what their clinical progress should be. But again, immediate follow-up is absolutely crucial to ensure that those patients remain safe. Why do some patients not have a cough? Again, it depends. Most of the cough seems to be related to an upper airway sinusitis with a postnasal drip. We've done a lot of nasal douche with sinus washouts, because patients also have a lot of bleeding in their sinuses, and then the leaking down the throat that causes this dry cough. But again, it depends on at what stage and how severe the inflammatory response is, what symptoms the patient presents with. So the cough really indicates to us what kind of presentation that particular patient has. So if you hear this dry cough where they just have almost like a wheezing, that seems to be the more pliable lung. They don't have a big infiltrate. They may have some crepitations in the lung when you listen. Where they have the very wet cough, those are the patients where we really, really at risk of the more aggressive form, where the lung compliance is affected, where they have these plugs in the airway, and these patients may require bronchoscopy to even clear those plugs adequately. There's been new data now, even on inhaled heparin, to help clear this. We've used bisolven, we've used hypertonic saline. All of these have helped to keep that inflammatory response at bay and to clear the airway, because once those plugs occur in the airway, it's very difficult for the patient to not be hypoxemic and require further ventilation. So that's been an important aspect, learning aspect from that point of view. Will there be a second wave? I think a second wave is really just that it's not being completely eradicated from our community or our society. I do think that with the lifting of the lockdown, there's going to be more social interaction. So I do think that we will see cases. Whether it's going to be a wave of cases, the international experience and some reports from the International Critical Care Society was that, especially in Europe, the new cases that they've seen have been milder. The patients have not been as severely ill. They've not had as many ventilated, and definitely not the same numbers and severity of illness as they did with the first part of the pandemic, when they had such massive numbers of patients and massive mortality. So I must say that I think looking at their experience, my feeling is that they've seen a milder form of the virus, and hopefully we would have the same experience. At the same time, as I've said before, social distancing, use your mask, hand hygiene, you know, all the normal boring stuff, absolutely just important to spread that message to the people around you. And if you are in a community setting, whether it be at a gym or in church or at a funeral or just eating out with friends, just to have that awareness that you have to just be vigilant and be very, very careful that you don't accidentally get exposed. It is important at the same time, it's a bit of a balance not to be paranoid about it, not to live in this constant fear. The majority of people actually got better very well without any sequelae, even though we've mentioned these patients that may have some complications. They've really been few of them. It's just important to be aware of it so that we don't miss those patients and neglect treating them. The staff who tested positive are struggling for 2 weeks and more. While they're back at work, it's not easy for them to take it slow. They need to see their doctors again. Yeah, so I think, again, one has to just also be careful, because there are also situations where staff can have a psychological fear, again, of being back at work, and that they have sort of carry the sequelae of that infection with them. At the same time, I think if the person is struggling, the management should keep that in mind. You can't have everybody sitting at home resting, but maybe to reduce the workload on that particular staff member, just to give them time to recover. A lot of it also has to do with attitude. I've seen people that just have a positive demeanor, really just getting back to work and carrying on, and it's as if they've just had a temporary illness that have gone away. And I think that is really important to support those staff members that are battling from a psychological point of view, because I do think that's where some of the symptoms may come from. You've asked here, what about prescribing for diabetics who have severe backache and unable to sleep on their backs? We've tried to actually get people to sleep on their stomachs, because we want them to open the back of their lungs. So the prone position has really been useful in getting the symptoms under control. We do treat with antispasmodics for the back. Often physio may be necessary, and then exercise to improve the back muscles and to ensure that, again, if they've had this from coughing, we do use a combination sometimes of a short course of anti-inflammatories if they need it, as long as their kidney function is normal and they are hydrating well, just to ensure that they're not dehydrated and that there's a risk of kidney infection or kidney failure. We've not seen as many kidney failure patients as they have overseas. And this again may be related to the fact that we were picking up patients early, and that the patients who did need dialysis, again, luckily were not as many as they saw overseas. It was as high as 15% of patients required some kind of dialysis or kidney support. So there's a question about the subset with severe disease have an aggressive immune response. Yeah, so I think the subset of patients with a more severe presentation, we've used the tocilizumab in these patients very effectively. We've had interleukin-6 levels of over 4,000, improving back to normal. Remdesivir is now available, and again, it's an antiviral agent, whereas tocilizumab is an anti-interleukin-6 agent, and the dexamethasone has made a big difference. So I think those combinations in these more severe patients, definitely in my mind and with our experience in my patients, in my particular group, in my own patients, I've had over 200, and we've had a very, very good response in the severely ill patients with these agents. So I must say, I think it's made a big difference. Even though it was used off-label, it's made a big difference to our patients. I've only had one patient that's on oxygen. He's a bad diabetic, and he had a very severe form of the disease. Unfortunately, he had to leave the hospital early because his wife was ill, and she subsequently passed away from COVID at another hospital. And then he was readmitted. His COVID test was negative, but he clearly has this pulmonary fibrosis that we speak of. So that's one patient that I've had issues with in the long run. The question about, is it possible that the subset will have a severe reaction to the vaccine? I think the vaccine needs to be tested to make sure it's safe, and they won't have a reaction to it. I think they would just, again, have a better chance of not getting another infection if the vaccine is proven to be effective. So again, that's one of the things that will be tested in time, and it's very difficult to predict it at this stage. And that is why I think there are already 2 vaccines being tested in South Africa. And as you know, multiple countries are doing these tests to see if we can get to an answer. Because from that point of view, again, the virus may change. There may be a different virus coming across. We have to see how we get rid of this one. But it may give us some insight into how to prevent a future event, such as what we've experienced in the last few months. Can I just confirm that after 5 days? Yeah, so the new recommendation is that 5 days would be the time that patients need to quarantine, not 14 days. Then it was 8 days, then it was 10 days, etc. So 5 days really is the new recommendation. And that seems to be quite adequate for the self-isolation. And after that, really, the risk of spreading to somebody else would be very low. Then how do you prescribe steroids? So we actually would continue steroids for 10 to 14 days after discharge from hospital. So we would go with oral prednisolone, and normally between 30 to 40 milligrams. If the patient is diabetic, we would cover them with insulin at that time, and to ensure that they don't have hyperglycemia. And we found that that was the adequate period of time. We're also very careful that we give them potassium, because remember, steroids can drop your potassium, and we don't want them to be at risk of hypokalemia, which can again add to the fatigue. And we also covered them with a proton pump inhibitor to ensure that they don't have a risk of GIT side effects at the same time. How long is the lung compliance problems with patients after recuperating? Just a question about, do we still tell people to sleep prone at home? Yes, I have done that. I found that patients were more comfortable. And even though they are symptomatically much better, some still had this heavy feeling in their chest, which took some time to get better. I had the same experience myself when I had COVID, that it took some time for those symptoms to improve. And by sleeping prone, you actually improved the symptoms, and you could have a good night's rest. So I found that to be quite useful, as long as the patients can do it safely and they feel comfortable. The steroids we've said, and the lung compliance problems. So the lung fibrosis, this complication that I spoke about, luckily doesn't affect many patients, but this may be permanent, and unfortunately may result in the patient becoming a respiratory cripple. Luckily, it's not been in many patients. As I said, I've had this one patient that's had persistent problems, but even in him, he's slowly improving. And we hope that with the treatment that we've given, that we can improve him in the long run. So he is still on home oxygen at the moment. And he has really been completely asymptomatic before COVID-19 of any lung disease. He's never been a smoker, but he does have a history of diabetes, and he was poorly controlled before the COVID-19 infection. The comments on steroids in diabetics, as I've said, we're very careful. If you look at the patients with the severe form of COVID, they also were insulin resistant, so they needed higher doses of insulin to get the sugar under control. And we often had to resort to an insulin infusion to keep the sugar between 6 to 8 millimoles per liter in the intensive care setting. In the wards, we could use pre and post-meal short-acting insulin to keep them under control. If they were newly diagnosed patients, we would start them on tablets at the same time as initiating insulin. And then as the tablets kicked in and the sugar came under control and the COVID-19 infection improved, we could then stop the insulin. And again, those patients just have to be monitored very carefully, and we keep a close eye on their home monitoring to be able to intervene as required. Steroids clearly would push the sugars up, and even if the patient was not a diabetic, we would treat them with insulin to keep the sugar in the intensive care setting between 6 to 8 millimoles per liter. And if you look at the patient with diabetes itself, we would look at the HbA1c on admission. The newly diagnosed patients, all of them had HbA1c levels that were elevated, indicating that they had diabetes that was unrecognized before they developed the COVID-19. And the COVID-19 really just brought out the symptoms, and we picked up the diabetes when they were admitted to hospital. So they would be treated as new diabetics, happen to have COVID, and get both of the diseases under control. Chris, I think those are all the questions, unless I've missed one, and you can just highlight for me if I missed anything.
No, it looks like you've covered everything that I can see. We'll maybe give it one more round, just a little bit of time for maybe to raise their hand and type in additional questions. I think that was very thorough and very comprehensive. I didn't actually realize you had COVID yourself, so I think you've had first-hand experience the whole process.
Yeah, look, it's a miserable virus. I must say, you really don't feel well. Body pain, you know, that heavy feeling on the chest, and again, yeah, it's really it does affect you, and it really does give you a very, very bad muscle pain. And I didn't have much of a fever. The coughing, of course, you don't have a good sleep. And then the fatigue afterwards definitely does affect a person. And it took about, when I recovered, my SATs went down to 88%. And after that, luckily I didn't have to go to hospital. And after that, getting back to work, the first few days were difficult, but you push through. And I think important for me at the time was that I really just had to get back to treating my patients and being there for them.
Thank you. That's good to hear that, and I'm glad you've recovered. You mentioned that you were tired.
Sorry, just one question about early diabetics, of patients being more predisposed. Yes. So there seems to be definitely that uncontrolled diabetics, because of the immune response, have a higher risk of developing COVID, and the high sugar then made them more ill. So that is definitely a problem that was of real importance that we learned. You know, we were all worried about patients with HIV and TB, and that really was never a big part of what we were dealing with at all. I think I had one patient who's HIV positive who had, but had very good viral suppression and a good CD4 count. And although he was in ICU for a period on high flow nasal cannula, he actually recovered very easily with no problems. Obesity, again, with diabetes, of course, drives the inflammatory response. And I think that obesity factor, we had some really, really overweight patients. I had one lady, probably about 130 kilos, but she could sleep prone, and she did very, very well on high flow nasal cannula. I saw her and follow up at my rooms, and she's had a fantastic recovery. And so I think obesity, although it may drive the inflammatory response, again, was found to be a major risk factor. But again, patients, if they were seen early enough, we could really intervene and get them better. So obesity, although a factor, and of course an overweight diabetic, probably the worst combination of comorbidities that we had to face.
Sorry, Adri, I have one question, or sorry, Jeff King, I'm going to try and unmute you. He just sent me a message. I see
yes, sure.
Thanks.
Jeff?
Thanks. Adri, thanks very much. I'm quite interested in terms of the diabetic, especially in the way we're using steroids. Is there any evidence that we need to give steroids in the mild cases? Because I find a lot of doctors are using steroids early on and giving them with the vitamins. I mean, the data shows that it doesn't really help, except in the dexamethasone type of situation in our very severe cases with respiratory disease.
Yeah.
Comments on that?
Yeah, I think that you know, there's no benefit in giving what's called preventative steroids. So oral steroids given in a patient who have mild symptoms, definitely not. In fact, that could worsen the viral replication. So the dexamethasone and even the prednisolone that we use when the patients recover has been in the patient in hospital with severe disease who have lung infiltration. You see the crepitations, you hear the crepitations, they have the inflammatory markers that are elevated. That's the situation where we would use the dexamethasone, and we would then follow up with oral steroids once the patient's drip comes down. And the recommendation is, again, 10 to 14 days, depending on the severity of the illness. And in that situation, of course, we had to cover them then with insulin to ensure that their sugar was under control if they happen to be diabetic. And even if they're not diabetic, we still monitored the sugars very carefully, because the high glucose could, again, worsen the inflammatory response in that patient. I agree.
They're very interesting cases, because I've had 2 cases recently where the issue related to the level of actual insulin requirements, because they seem to go through a phase of type 2 almost creating a failed insulin secretion because of the way the ACE2 is working on the actual beta cell in the pancreas. And I'm interested to know whether your particular cases have that, because I've had 2 patients now that have obviously become insulin dependent. Interestingly, the one patient was already taking SGLT2s. In fact, both patients were taking SGLT2s together with glucophage, and they're now needing insulin. And what I find is that the insulin requirements are quite high, especially the ones that are a bit more severe. I suspect that that's related to the actual degree of inflammation. And then the question is, what's your choice of insulin? Because remember, as we know from the cardiac side, the biggest problem is the heart failure in diabetics. You know, with SGLT2s, I've always made the point that it's not a great drug to actually treat the diabetes. It's more to treat the actual effects in terms of decreasing hospitalization for heart failure, because these patients are very prone to developing heart failure. So one's got to watch their cardiac status very carefully. Number 2, what I've noticed is that if you give them too much insulin, they become a problem too, because again, which insulin would you give to a patient these days in the post-COVID sort of situation? Because there are many types of different forms of diabetic therapies that will enhance the actual incidence of cardiac failure. So would you recommend still sticking to normal Lantus, Levemir, those type of things, or would you rather go long-acting?
So look, it depends on the patient, and I must say I haven't had any heart failure patients in the entire group that I saw. And as I said, of my patients that I saw with COVID, really, I've had no cardiac sequelae on any of them. I've had the pulmonary emboli on 3 patients, and these one of them was a diabetic, but the others were only like COVID itself. So I must say that I've just treated them the same as I would normal diabetes, but patients where it depends on how they respond. So you do get a person that could be very insulin resistant, and that's where we used intravenous insulin to get those sugar levels under control. And we've had patients where we had to use 14 or 16 or 20 units an hour to really get the sugar under control. And then as they improved, we could adjust their insulin requirements. So there's a definite insulin resistance that may occur with these patients. Long term, again, it depends on the patient's response. And if you look at, for example, the GLP-1 receptor agonists, these agents has not been well studied in the COVID situation, but they would make sense because they have an anti-inflammatory effect as well. And this may be, again, from the SGLT2 inhibitor side, the anti-inflammatory effect, you know, the whole story about the heart failure and the way that they improve the rheology in the heart may again be of relevance from that side. But that's purely a diabetes discussion and not really on the COVID side, because they've not been studied as such. We know that insulin does work, and I've used short-acting insulin. And if you then need high doses, we've brought in a basal insulin. and even pre-mix insulins where you can combine short and long acting. And again, depending on the patient's response, what is necessary. We've used metformin depending on the patient's renal function. And again, the patients where there's been a good recovery, we've not needed to do anything more than normal diabetic follow-up on those patients. So again, there's no specific preference really. It depends on that individual patient. And then, as always, in our setting, what the medical aid would pay for and what they would allow us to use in the long run.
Okay, there's an interesting observation, because have you looked at your patients postprandially? You know, I know that
we do that automatically, Jeff. That's why I said we do pre-meals and we do 2 hours postprandial on the patients that's not on intravenous where they ventilated. It's a different story.
Well, can I put it to you that my observation has been that these patients are much worse. They're almost in a situation of failed insulin secretion. So the ACE2 inhibitor, the ACE2 stimulation is actually resulting in this failed or presumed insulin resistance. Surely we need to then address them with much higher values. So those patients that you're talking about that are requiring 20 units per hour, those patients will probably do better with long-acting type of insulins. Number two, is this going to be reversible? Because remember, most of the time that we hope that these conditions are reversible, but with COVID's effect in terms of the actual beta cell, my concern is that these patients are going to almost land up like a type 1 type of situation. Because I've seen 2 now that are really running high values in terms of the actual instance required.
I think from the American Diabetes Association as well as the European Association for Diabetes, they've also been following the COVID pandemic across the international spectrum. So not just our patients here. And there's been no real change in the recommendations as far as the management is concerned. They may, in that acute setting, need these high doses of insulin. And then depending on how they respond, we would then adjust to a long-acting or alternative therapies, depending on how the patient respond. So it's a bit difficult to generalize on 2 patients. I think you have to be careful not to overinterpret as well, because if you look at, my patients I've had since February, I think, was some of our first experiences, some of our patients from early March that we've had. And again, follow up after 6 weeks, some of them 3 months, now 6 months. Not really any major difference in how we manage them. We monitor their HbA1c levels clearly, and we will adjust the treatment accordingly. So I must say, I haven't seen anything really massively different. Obviously, in the acute phase, they are using up their reserve, but again, depending on how you approach that patient, you would be able to manage them as you would do with your normal diabetic patients. So I think that the immediate COVID situation when they're ill, different story to the long-term management of the patient. There was also a question about the vitamin D then, Chris. I think from that side, again, there were some recommendations. You know, in South Africa, if you're an hour in the sun, you have enough vitamin D for a month. This assay that is done, we didn't do blood tests. We just used the vitamin D as a supplementation. We didn't find that it made a massive difference, although it was part of the recommendations from the Gauteng ICU group, and we did use it, but I didn't follow up to give that in the long run to the patients. I didn't find that necessary. And then there was a question about, did you find some patients who tested negative were more critical ill than those who tested positive? I'm not quite sure what is meant by that, but again, you know, if patients, there could be patients where the COVID swab was done poorly or the test was not adequate to the laboratory, and if there was a high suspicion, we would still treat them as COVID positive, looking at the inflammatory markers and again just re-swab them and see if we can find a positive test. So we didn't really find a situation there where patients were negative. They could have had other illnesses. I've had one patient that had a PCP pneumonia that was a newly diagnosed HIV patient. So again, you know, not everything is COVID, and one has to just be careful that you don't misinterpret as well, that the patient could have something else. There's still patients who get strep pneumonia, ARDS, and I had one of those patients that was COVID negative. And those patients need to be treated like we normally would manage them in the intensive care unit setting.
Perfect. Thanks so much, Audrey. I think I'm just conscious of time as well, and also of your time.
Sure.
Thank you
you
so much for the session. I think it was very informative and just really practical. I'm sure there's a lot of people out there who are struggling with these patients on a day-to-day basis, and your experience and your knowledge are immensely valuable.
Thank you.
So we'll close off the session there. Mandy, are you still online? I'm sure Mandy's there, but she's probably just showing with the mic.
Yeah, I'm just struggling with the unmute button now. I'm only a nurse. Chris, no, thank you, Audrey. I really appreciate it. Just to let you know that our next talk is the comorbid COVID patient on the 24th of August, the doctor from Sunninghill. So I think he's going to talk about comorbidities in the COVID patient. We'll see what comes up then. Thank you, Audrey. I really appreciate your time.
Thanks very much, everybody. Thanks for attending. Cheers. Have a good evening.
Good night, everybody. See you soon.